If we know that guide wires play an important part in the toolbox of the CTO angioplasty along with the other material, and these are the fundamental anti-grade strategies. Anti-grade wire escalation, de-escalation, that is first step, first strategy. Suppose if the fails, other strategies are parallel wire techniques and image guided wire entry, especially IVS guided, and anti-grade dissection re-entry and 3D wiring. And these are the pre-Gaia era, these are the fundamental characters of CTO wires. Penetration, the force with which you can penetrate the cap and CTO, and pushability, especially crossing high resistant chronic occlusions, and steerability, and shaping the memory of the tip. And grossly pre-Gaia era, they are classified into hydrophilic guide wires. The major mechanism is tracking through microchannels, and non-coated coil wires, mainly the high resistance CTO with a good tactile feel, you can penetrate as well as you can drill the CTO body. And pre-Gaia era, these four are the important, by strategy, there are four important types of the wires. Tapered low tip polymer coated hydrophilic coating, that is a filter series, which are mainly meant for the tracking the microchannels and soft tissue probing. And non-tapered, especially low tip force, either with or without polymer. Without polymer is ion, with polymer is fielder FC series. And non-tapered moderate high gram tip force with polymer coating, that is a pilot series. And of course, a tapered high gram tip force and hydrophilic without polymer, that is a series. With tapered is confluenza, non-tapered is a miracle series. And by means of tip load, there are mainly three types: soft, intermediate and stiff. Soft is less than 1 grams, fielder series they will come, and intermediate between 1 gram to 4 grams, that is Gaia, Ultimate Brother, Miracle Neo 3 and Gaia Next 2. And stiff is more than 4 grams, especially Gaia 3rd and Gaia Next and Conquest Pro, Miracle series, they will come under more than 4 grams tip load. And the important role of the soft wires, especially less than 1 grams, fielder XT series. And the tip load of for fielder XT is 0.8 grams and fielder XTA is 1 gram and fielder XTR is 0.6 grams. So fielder XTA is mainly important to anti-gradely to penetrate the proximal cap to keep in the microchannel. And fielder XTR mainly trackability, so collateral crossing is the predominant use. Of course, subtotal occlusion also we can use if presence of microchannels. So this is the important pathology of the CTO by which the anti-grade wires are mainly designed. And the admixture, the CTO body is admixed with a microchannels, soft tissue and hard tissue. And as we know, the microchannels are 200 micron size. The tapered tip hydrophilic wires, especially 0.009 tapered, that is 230 micron size, which can track the microchannels effectively. And this is an anti-grade wire strategy. If the angiographically visible microchannels are there, you can select fielder XTR as a first, then you can escalate to Gaia second if any friction is there. Then if the proximal cap is tapered, you select fielder XTA. And if there any friction is there to penetrate Gaia second, you can escalate. And if it is a proximal cap is a blunt or ambiguous, you can take a fielder Gaia series as the first one, you can escalate to Conquest Pro. And CTO body short length less than 20, you can step down to soft wires. And if it is more than 20, you can continue with the soft wires or you can escalate to either Miracle, Ultimate, Bros or Gaia. And distal cap also you have to sometimes escalate to the more penetrating, more stiffer wires to penetrate the distal cap. And this is the one where the visible microchannels are dual angiogram, you can see. So where fielder XTR we selected ultimately with the help of the microcatheter which passed through the CTO body and successfully revascularized. Then the Gaia, it totally changed the anti-grade strategy, especially by means of deflection and rotation, in the intended direction, you can pass the wire, and because it has a composite core technology. And this is the diagrammatic depiction of how you can keep the wire tip straight and you can change the direction and tip. And basically Gaia is meant for soft tissue dissection. And sometimes if any friction is there with the encounter of hard tissue, you can escalate to the Gaia third or Gaia next or conquest. So this is the one Gaia second. You can see there is a ambiguous cap with the side branch. You can deflect the tip toward the proximal cap and you can able to penetrate the proximal cap effectively. So this is a long segment CTO where the Gaia first, which you by means of orthogonal planes of LA or RO of RCA CTO, you can have a buckling. So then we escalate it to Gaia second. Ultimately, effectively it crosses the CTO body and successfully we revascularize. And this is also, you can see the LAD CTO where you can pass the proximal cap and proximal cap CTO and distal cap where Gaia second is buckling. Then we escalate it to Gaia third, so you can penetrate the tough distal cap and enter the distal vessel. And this is also, you can see the Gaia second, where at the distal cap it is difficult to penetrate, and ultimately by escalating Gaia second, you can penetrate the distal cap and enter the distal target vessel. And here you can see the single wire only, the Gaia second, you can, after distal cap, it went into subintima. Again, you can pull back and then deflect it towards the tuft of distal cap and enter the distal true lumen effectively and revascularize the vessel. And of course, the most important, you can select with the field XT and or if visible microchannels are there. And suppose sometimes they end with the soft tissue or hard tissue, you can escalate to Gaia. And then if ambiguous body is there, you can penetrate the distal cap by again re-escalate to the Gaia third, and you can enter into the distal lumen very effectively by means of this technique. Of course, the Conquest Pro, especially useful for the tough proximal cap and distal cap, and sometimes as a parallel wire also, which can use as a stiffer wire, and heavy calcified lesions also to penetrate the hard tissue, this can be used. And here the distal cap is very tough, where with the Conquest Pro, you can penetrate and the pass it the wire. And of course, this extend coil technology, Gaia Next, had a more penetrating force and anti-breakage and anti-trapping mechanisms. You can pass the hard tissue very effectively with the Gaia third, Gaia Next. So, anti-gate wire escalation, de-escalation strategy, which is a very, very important, every CTO operator has to, is a fundamental first step and first technology, which you can effectively, majority of the cases, almost 60 to 70 pages you can finish. Of course, the difficult, as the complexity is more and more, you can follow the other strategies, and Gaia handling and manipulation improve the success rate of anti-gate strategy, especially in short segment and medium length CTO. Just I will represent one case I will illustrate. A 33-year-old gentleman having unstable angina, he had underwent angioplasty to LAD and RCA. He is having risk factors of hypertension, diabetes with good LV function. So dual angiogram showing a patent LAD stent and RCA proximal ISR and distal CTO segment is there with a poor interventional collaterals. And with that, it's just about to complete. And the CTO wiring initially with the Gaia first we started, and it went into extra block, and then it pulled back and redirected towards the lumen. But at the distal to the CTO, we are finding a difficult to pass the second step CTO. Then we escalated to Gaia second, and it is tracking towards the side branch than the distal one. Then immediately, with the help of the fine cross and the guidezilla, we passed the microcatheter towards the just tip, and then we de-escalated to pilot 50, and then effectively crossed the distal lumen and distal CTO, and we wired the into the PDA, the distal lumen, and then the balloon uncrossability, even 1 mm is also not going at the distal CTO. Immediately we change it to Nick Nano 0.8 mm with guidezilla and then with L backup, and then dilated with the 2 mm balloon, and then Guidezilla advanced with inchworm technique to deliver the long stent, and ultimately proximal and distally we stented, and finally with a post-stent dilatation with 3 into 12 NC balloon, we got the good result, final result. So in conclusion, in this case, a sequential RCCT is a challenging subset by anti-grade technique. In the present case, anti-grade wire escalation by Gaia first and second, and then intense intimal tracking and de-escalation successfully wired the CTO, and then Guidezilla provide the power guide for delivering balloons and stents, and Nickinano will be used for a balloon uncrossable lesion, and inchworm technique used for passing Guidezilla till mid-segment of RCA, automatically to increase the support for delivering the long stent. Thank you.